Thank you so much, Dr. Han, for having us. It's an honor to present here this year again. So I'm Stina Pirpchen, and I'll start and I'll pass along to Dr. Baptiste after my part is complete. And so we prepared this lecture with Dr. Baptiste, who you'll meet in the next 15 minutes. And we have no disclosures. So the learning objectives for the participants after this session is for the participants to be able to sorry, I have issues with this. Okay, share screen. So by the end of the session, we would like the participants to describe Colombia's approach to helping PKD patients evaluate their reproductive options, explain the process of embryo genetic testing for PKD, and it's one of the reproductive options, but not the only reproductive option for this patient group. And also, Dr. Baptiste will focus on the best practices in the care of patients with PKD. So both Dr. Baptiste and I, we are a part of the pre-pregnancy genetics program at Columbia. So we provide multidisciplinary expertise to help couples who are at risk of passing a genetic condition and learning their options and minimizing the risk of severe genetic conditions if they wish to choose embryo genetic testing. And we give personalized genetic counseling with the help of the women's genetics team. And we help the patients understand better what would be the best for them, whether testing before pregnancy, during pregnancy, or after birth, based on the specific condition and also based on that family's preference. And also, we internally review the diagnostic approaches and the strategies of the labs and with our scientists. So we are medical geneticists like Dr. Baptiste, fertility specialists like me, our genetic counselors, our scientists. So, and also this program extends to the whole Columbia network. So if it's a kidney condition, it's Dr. Han, Natalie, Kelsey. So they are also a part of the pre-pregnancy genetics program. So we have priority spots for patients who are at risk of genetic conditions. And so if a patient is at risk of passing on PKD, they'll have a schedule placed in my schedule immediately. And the same for Dr. Baptiste. She'll also give priority for the patients that are coming from our program. And so we give the patients personalized support from the very first point of contact. So when a patient who is at risk of passing on a genetic condition is scheduled, as soon as they start their consult, I tell them about the support from Women's Mental Health Program, the support from Women's Genetics. So at each and every step, the patients are supported. For example, Women's Mental Health Program and Pre-Pregnancy Genetics Program, we have a partnership and we give the patients individualized support because those patients are not infertility patients. They're going through IVF because they're at risk of a genetic condition. So the approach is much different and the uncertainty is different. The challenges, the mental challenges, emotional challenges are different. So when we talk about reproductive options, what are the reproductive options? So if it's a single female, she could choose egg freezing for future embryo genetic testing for PKD. Or if it's a couple, they could choose embryo freezing with embryo genetic testing, and they could be ready for pregnancy now or later, like the example that I'll give later in this presentation. Also, they could choose egg donation if the female partner is at risk. They could choose sperm donation if the male partner is at risk. Also, they can choose not to test for PKD, and they could opt for natural pregnancy. Or the patient's health conditions could be requiring gestational surrogacy if the person is at risk of severe kidney failure with the pregnancy, Okay, so I'll briefly review the ovarian stimulation and IVF process, and then the embryo genetic testing process, and after that, give you an example too, after I set the base. So ovarian stimulation, when we say ovarian stimulation, we give natural hormones, follicle stimulating hormone and LH hormone. And then we collect the eggs when the patient receives anesthesia. So the egg collection is through a vaginal ultrasound. We harvest the follicular fluid, and then we collect the eggs. We pass the eggs in tubes to our embryologists. And then we inject the eggs with the sperm of the partner. And then we culture the embryos, the eggs that get fertilized to 1 week stage. So this is day 1 of egg development, and this is day 2, day 3, and about here, there's about 50 cells or so, and here is about 100 cells, okay? So day 5, day 6, day 7, when they reach to that blastocyst state, and you can differentiate what makes the baby and what makes the placenta, you could biopsy 5 to 8 cells from what makes the placenta. And then after we get the genetic testing results, we transfer the embryo that is unaffected. And this is how the pregnancy occurs. The transfer process, it does not require anesthesia. It can even be done 1 week after ovulation in a natural cycle. So today, when I say PGT, I'll be talking about pre-implantation genetic testing. And PGTA is what we do for pretty much any infertile couple who is asking for testing their embryos for things like Down syndrome. That's aneuploidy testing. So it's about 80% or so of the couples in the United States actually do embryo genetic testing for aneuploidy, 60 to 80%. And PGTM, this is for single gene testing. So in our case, it's going to be PKD, and PGTSR and PGTHLA does not apply to us today. So we need an embryo genetic testing setup, PGTM setup, okay? So when you are testing your patient for the PKD, when you're establishing molecular diagnosis, you either it's a blood sample or a saliva sample. So you don't need a prior preparation. Why? Because there are actually hundreds of cells there. You don't need to amplify DNA. But when you are working with such a small structure like the embryo, it's such a small amount of DNA, we need to amplify that DNA. And if we don't look at the surrounding markers, there is a risk of allele dropout or allele drop in. So we look at the surrounding markers to make sure we are accurately detecting the embryo, whether the embryo is affected or not. Okay. So this probe development takes about 5 to 8 weeks, and DNA collection is primarily from the couple. And in most cases, we can establish the diagnosis from only linked markers and the arrested embryos. And in some cases, some additional DNA may be needed from affected family members. And in PKD, it could be there is a pseudogene in the PKD gene. And so depending on the location of the mutation, the family members' genetic testing and DNA samples may be required. In not all cases, but in several cases it will be required. And also one of the things that may come up in this very well-versed patient group, if this is a new mutation of PKD, could the test development be possible? In most cases, it can be possible, but it all depends on the variant. And so the probes are designed based on that pathogenic marker and informative markers. Then there is, once we are sure we can detect the variant in a single level, then we say, okay, you're good to go. The patient can start the cycle. So the linked markers, to make it a little bit more concrete, I want to give this report as an example. This is a different condition. This is BRCA1, but the same principle applies. So you could see the variant in this patient, and the variant is in red, the affected variant. This is the affected mutation. And these are the upstream and downstream markers that are associated with the variant, which is the patient is here, BRCA737. So anything that's associated with the red is affected status. So we are looking at the markers that is associated with her mutation, that comes along with her mutation before and after, when we are calling the embryo affected or not. So we are not only one time sure, we are several times sure that we are detecting the variant. And also you can see we are reporting the chromosome numbers of the embryo, things like Down syndrome. So it will be also reported. So we know the variant most of the time. We could test the embryos for that. So PKD falls into that autosomal dominant category. And so I'll give one example of one of our patients. So 30-year-old G0 female, she has PKD, and with her partner, they are interested in embryogenetic testing. She has a history of carotid dissections in her young age, and her father, sister, and brother also have PKD. And she's on labetalol for hypertension, and she has really good ovarian reserve. Her AMH is 7.3, and this is a marker, surrogate marker of ovarian reserve, and a good baseline follicle count. Her partner's semen analysis is normal, he's healthy. She also has established molecular diagnosis with the pathogenic variant in the PKD gene. So she goes through ovarian stimulation, and they're actually both scientists, and they were so informed that they should do this well before they reached their late 30s. So she has a perfect cycle, really, with the minimal amount of medication. She responded really well. And in the end of the cycle, we got 15 embryos that were biopsied and frozen. And with each stage, you will see there is an elimination. Not all the eggs will be mature, not all the eggs will fertilize with the sperm, and not all of them will progress to 1 week stage. So from the 15 embryos, 5 were chromosomally normal and unaffected, 6 were chromosomally normal but affected, and 4 were chromosomally abnormal. And they're still not ready for pregnancy, but when she's ready for the transfer of her embryo, she'll need the support of women's genetics. Dr. Baptiste will take over in a minute, nephrology, cardiovascular surgery, and maternal fetal medicine team. And then let's say in the case, hopefully she'll be very healthy for several years. Let's say in a case a patient goes through kidney failure, or they're not, they discuss their condition with Dr. Baptiste and they're not recommended for pregnancy. So patients who cannot carry a pregnancy due to medical reasons, posing a danger to mom's health, they could be eligible for gestational surrogacy. There are some legal and ethical considerations, of course, and the timeline could take about 2 years or so. And of course, this is a costly process, over $100,000. And a little bit about the cost of the embryogenetic testing. So the good news in New York State, most private insurances, they cover IVF or embryogenetic testing. And patients with no insurance or with Medicaid, they actually have significantly discounted rates with our fellow clinic, and our program supervises those patients. And and also there are financial possibilities like Bonai Olam, 8 Times, Stardust, or Resolve.org has a list of organizations that could give financial support to the patients. But as a final slide for me, I put the PKD-Free organization that gives support to many, many patients. Mr. Rich Kellner is leading that cause, and he's leading this PKD-Free Alliance that's helping now over 100 families, and we're also partnering with them. So if you're a patient, PKD patient, or if you have a PKD patient that is not able to have private insurance that would cover IVF, embryogenetic testing, please contact PKD-Free program. Okay, so I'll stop sharing
Okay.
and pass to Dr. Baptiste.
I will start sharing then. All right, can everybody see? All right, so I'm Dr. Katie Baptiste. Thanks for the introduction earlier. I'm one of the MFM, maternal fetal medicine, and geneticists here in the Department of OB, and I work with everybody on the call closely. So just kind of a little introduction to the division of women's genetics. It's a little bit unique, but we essentially provide care to families with genetic disease that can impact reproduction and then really women's health over the course of their lifetime. So we have a team of 2 MFM geneticists and then 7 or 8 genetic counselors who see patients prior to pregnancy, during pregnancy, and then after pregnancy for lifelong women's genetics disease. We provide preconception counseling to talk to patients if there's a known family history of genetic disease, or for example, if we know that somebody has autosomal dominant PKD, and we can kind of talk to them about what reproductive options look like. And then of course, we meet patients during pregnancy to again talk about risk of inheritance to their offspring, and then the options for prenatal genetic diagnosis. If we diagnose a fetus with what we think is genetic disease, for example, like autosomal recessive polycystic kidney disease, then we would, of course, take care of them throughout that process as well. When we see patients preconceptionally, which is ideally when we would see patients with complex medical conditions or really any known genetic disease, we would love to see them prior to pregnancy to make sure that we have a good plan in place for them. If they don't have a molecular or genetically confirmed diagnosis of a clinical condition like PKD, I can either send testing myself or work with my colleagues in medicine to obtain a molecular diagnosis and confirm genetically what we think is going on clinically. And that will allow us to not only know the exact variant and its pathogenicity, and make sure that we have really the right diagnosis, but also allows us to understand the mode of inheritance to their children. And then just like Dr. Kripchen said, we can then use that testing to know what our reproductive options are, and counsel patients so that they're building their family in the way that they want. We would also do baseline routine carrier screening, which looks for more common autosomal recessive conditions that you really need the partner in which you're having the pregnancy with, or the gamete donor, the sperm or the egg donor, to make sure that you're compatible genetically to have a baby without genetic disease. And then we just do a 3-generation pedigree to really assess for any familial risk of genetic disease prior to pregnancy. On the medical perspective, if I'm taking care of a mom that's going to be pregnant with PKD, I want to make sure she's not on any known teratogenic drugs. And then if she's on an antihypertensive that is not safe in pregnancy, want to make sure we get her hypertension well controlled, just prior to pregnancy on a medication that's safe during pregnancy. We commonly use labetalol and nifedipine, but would definitely work with the nephrology team to make sure that we're all on the same page. And then we would review kind of risks going forward and what we would watch for during the pregnancy to make sure that mom stays safe. Patients with PKD, as you all know, are at risk of worsening hypertension during pregnancy and then developing preeclampsia, which is a hypertensive disorder of pregnancy that patients with chronic kidney disease are more at risk for. And then because of those two things, they're also at risk for delivering early, not necessarily because they go into labor early, but because perhaps their hypertension worsens or their kidney disease worsens or they get preeclampsia, and we feel that it's safest for mom and for baby to deliver them early. So we may recommend delivering early to keep both mom and baby safe. But that, of course, comes with some of the risks of prematurity, which is why many of these women would follow with our high-risk team. During pregnancy, prenatal diagnosis options include chorionic villus sampling or an amniocentesis. Those really differ based on when we can do them in the pregnancy. A chorionic villus sampling, I think it really is just a placental biopsy, and we do that at 11 to 14 weeks of the pregnancy, which is really just the end of the first trimester. And amniocentesis, which many more people have heard of, is really just sampling the amniotic fluid. And we can do that safely after 16 weeks of the pregnancy and really until the end of the pregnancy. So for some patients, for whatever reason, either they don't get to us early or they want to defer that testing, and we can offer prenatal genetic diagnosis really throughout the entire pregnancy once we kind of are out of the very first part of the first trimester. What can we send off of prenatal genetic diagnosis? We really can send almost any genetic test. So historically, we were sending karyotypes to rule out things like chromosomal disorders such as Down syndrome. And for a while, for about a decade now, we've been sending microarray, which looks for certain microdeletions and duplications. But now we're able to test for single gene disorders like PKD. So if we know mom or dad's variant and we want to test for a specific variant, we can do that. If we want to take a much broader approach, we can also send things like whole exome and whole genome sequencing. And the way to access that differs. We routinely, and insurance currently covers most exome and genome sequencing if there's a concern for genetic disease. So for example, again, if we had an autosomal recessive polycystic kidney disease and the fetus had, enlarged cystic kidneys, we would probably get coverage to do genome or exome for that. But we also have a program here to offer really whole genome sequencing to what we consider non-anomalous or normal appearing fetuses. But certainly if there was a concern for genetic disease, we can look for specific things as well. So really can offer a very focused approach for patients who want very focused answers and a very, very broad approach for patients who want almost like a genome screen at the time of early pregnancy. We focus on genes that impact childhood and maternal health. So if a patient elected for non-anomalous genome sequencing right now, and the fetus, had a de novo PKD, we kind of have to talk about whether we would report it. But certainly if it was inherited from mom and for whatever reason mom didn't have a diagnosis yet, we would report that really to keep mom healthy throughout the pregnancy. Just kind of flip-flopping back and forth between the fetus and the genetics portion and taking care of a mom with PKD. Throughout the pregnancy, we want to make sure that mom is healthy, that she has regular monthly assessments of her blood pressure, her kidney function, and her proteinuria. Either I can do that through regular obstetric care or in coordination with nephrology. We want to make sure mom is monitoring her blood pressure well at home and that her blood pressures are well controlled. In an attempt to prevent preeclampsia, we would recommend starting a low dose of aspirin at the end of the first trimester, and then screen for and treat asymptomatic bacteria. And like all pregnant patients, we want good fluid intake, lots of hydration. Labor and delivery, I won't get into too much, but hopefully we would have an uncomplicated pregnancy and get to term, and that pregnant patient can deliver vaginally at term, no need for a C-section just because of a history of PKD, or even a kidney transplant can still deliver vaginally and hopefully at term. There are other reasons that we sometimes deliver early, like poorly controlled chronic hypertension or new onset preeclampsia would kind of have us deliver early. Patients who do well can deliver locally with their local OB, and even if they come to us occasionally for consult during their pregnancy to make sure that they're being well taken care of, they can still deliver closer to home, which is always nice if, when you're expecting a baby, nobody wants to travel if they don't have to. And then we always want to either do testing either during the pregnancy or afterwards and make sure that baby's going to be referred to the right team to make sure the baby gets tested eventually if the baby's at risk. Postpartum, we want to make sure that mom's blood pressures are well controlled prior to discharge. We can either continue on breastfeeding safe antihypertensives, or if a patient is really having a hard time having their blood pressure controlled on some of our pregnancy safe blood pressure medications, we can switch back to pre-pregnancy antihypertensives kind of through shared decision making about how they're going to feed the baby and what is working best for them. We want to make sure that they're checking their blood pressure at home and that we see them in about a week to make sure their blood pressure is well controlled, and then we'll see them in the office in 6 weeks. Some meds still don't have enough safety data in nursing, so we will avoid some medications during breastfeeding. And then, like all women who deliver, sometimes need pelvic floor PT. We want to make sure that they are still in care with their nephrology team and then see them within 6 months after delivery. Sometimes pregnancy is a moment in time where patients currently don't have insurance, and then they get insurance during pregnancy, and so can have a really great care team during the pregnancy. And sometimes insurance gets changed or lost after delivery, so hopefully we want to make sure that they're still will have continued care after pregnancy. I think that's it. Thank you so much. This is the fertility team. It's a big group, just a few floors above us. And this is our women's genetics team, myself and one of their other geneticists, and then our team of genetic counselors. Thank you so much for having us. Really appreciate it and hope we can continue collaborating in the future.
Yeah, thank you for the great talk. As an internal medicine trained and a nephrology trained individual, it's pregnancy and the complications that arise and care is always something that has been challenging for me. So it's great to have specialists at our center that is working with us for our patients. So thank you both for the talk today. We do have a question. Dr. Kripson has been answering on the chat, but we have one question that is left. What is the minimum duration of stopping tolvaptan before getting pregnant? Likewise with stopping RAS inhibition.
Yeah, that's a good question. I usually recommend at least 3 months prior to the pregnancy, but I have to actually look specifically at tolvaptan. But I think the ACE inhibitor, I'd say 3 months, not because of the teratogenicity, but mostly just to make sure that their blood pressure is well controlled on the next regimen before coming into pregnancy. So.
Yeah, likewise to echo with Vaptan, I know that some of the metabolites has a very long half-life, but I'm not sure if that metabolite itself is a teratogenic component. So I think this we can definitely look further into this as well.
Yeah.
Great question.
That is a good question.
Yeah. So next question is, does pregnancy not require strict blood pressure control of 110?
It does not. So I'm sure my nephrologist and internal medicine doctors, like, their ears are going to hurt, but we let patients ride a little bit higher in pregnancy.
Yeah.
Our actual goal for most patients without polycystic kidney disease is even higher. It's like 140/90. But I'm sure our patients with kidney disease want them a little bit lower. If anybody wants to jump in, please do. Generally I try to keep patients under 135/85, but pregnancy-wise, I think it's fine to be that high if their kidney, function is not going to be impacted.
Right. I think I also echo that sentiment. I mean, a lot of the lower blood pressure goal was based off the HALT PKD study back in early 2010s. And I know like at that time there was decreased kidney volume growth when we targeted less than 110, but they just recently also published the 10-year data looking at progression to end-stage kidney disease and from my read of the paper that there doesn't seem to be too big of a difference, but so I think that 110 goal target is something that we still do clinically. But all this is also a very long-term outcome, right? And pregnancy is a 9-month outcome where we really have to make sure nothing goes wrong. My wife was just pregnant; she delivered a month ago, so it's like that time period is very important that no complications arises from there. So, but, although like in traditionally PKD care, we for younger high-risk patients we do target 110 less than, but I think during pregnancy it is we work together and we always end up targeting a little bit higher as well. The next question is, for women with PKD and liver cysts, IVF is contraindicated due to use of estrogen therapy included in the medication regimen. If not, should liver cysts be monitored before and after IVF, and how often?
That would require an individualized patient assessment with the specialists that observe the liver cysts. And because you don't give estrogen orally during IVF most of the time, like you always have an alternative. Your internal estrogen increases during IVF, so it would require discussion for that individual patient. But I wouldn't say it would be an upfront contraindication. Katie, do you have any thoughts about that?
No, I mean, I think that it goes along with what you were saying, Dr. Han, like pregnancy is a limited time. So certainly somebody with maybe liver cysts, you're not going to want to put on like a combined estrogen patch forever. But to get through something like embryo freezing or even the estrogen levels that they'll see in pregnancy is not a contraindication. I think, of course, if they have something huge that we want to optimize before pregnancy. That's always our goal, to see these patients before pregnancy to make sure there's nothing we need to treat or monitor, before we start them on an egg retrieval cycle or pregnancy. But I would imagine that it would be okay to just get them through the IVF cycle and then to maintain pregnancy.
Okay, and one last question. I think it's directed towards our fertility center, possibly. It says, do you offer telemedicine appointments for patients who might be living very far from specialized centers? If yes, what is the referral process?
You could actually go to the pre-pregnancy genetics program and fill in the patient contact form there. And the next business day, we'll reach out to you to schedule you. At the fertility center, we do provide consults for patients that live remotely and who would like to travel to New York for their fertility care. We do. And we have patients that live out of the country, in other places. And most patients can do their monitoring even out of state, but come here for the egg retrieval and the embryo transfer part. But if we are collaborating for their care, for example, with Dr. Han, we have a patient who is coming from Mexico. I have been doing their consults from Mexico. So we have examples of that. But, when he sees Dr. Han, he has to be in New York. When he sees our nephrology genetic counselors, he has to be in New York. But for the fertility center, telemedicine appointments are possible.
Thank you for that.
You.
Let's see. I think now we're a little bit over time, but thank you guys for taking the time. I learned so much from your talks.